Hi everyone, today we're going to discuss right ventricular anatomy and chamber quantification. So in the normal heart, the RV is the most anteriorly situated cardiac chamber and it lies immediately behind the sternum. The RV appears triangular when viewed from the side and crescent shaped when viewed in cross section. Under normal conditions, the interventricular septum is concave towards the LV in both systole and diastole. Three sections or compartments can be used to describe the right ventricle. So firstly, the inlet, which is composed of the tricuspid valve and its supporting apparatus, so the chordae tendineae and papillary muscles. Secondarily, the apex, which has coarse trabeculations. And then the third component or section would be the outlet, which is also known as the infundibulum or conus. And that's a smooth outflow region, or the smooth outflow region of the RV outflow tract and the pulmonary valve. The inlet is separated from the outlet by the parietal band plus the septal and moderator band. On the right side, the atrioventricular valve is the tricuspid valve, and there are three papillary muscles, anterior, posterior, and septal. In terms of other features, the RV wall is thinner than the LV wall. It's composed of a superficial and a deep muscle layer. The superficial layer is arranged circumferentially in a direction that runs parallel to the atrioventricular groove, and the deep fibers are longitudinally aligned from the base to the apex. And this configuration of muscle fibers means that contraction of the RV is predominantly longitudinal. This is in contrast to the arrangement of the LV, which is a bit more complex. So it has a superficial and a middle and a deep layer, and its movements include torsion, translation, and rotation. So now we'll look at how we assess the RV using transthoracic echo. So we start in the parasternal long axis view, and we obtain this view generally in the fourth-ish, but start in the fourth intercostal space to the left of the sternum, and the marker or pointer is towards the right shoulder. And in this image, we can see right at the top of the screen, most superficially is the chest wall, and deep to that is the anterior wall of the right ventricle, and then the RV cavity. The next view to image the RV is the parasternal long axis view of the RV inflow tract. And you obtain this view by, from the parasternal long axis view, tilting the beam down towards the patient's right hip. So you tilt the beam inferiorly. And this brings in the RV at the top of the screen there and the RA at the bottom. And in between them, the tricuspid valve. And you can see the anterior and posterior tricuspid valve leaflets. You may also see the eustachian valve, the ostia of the coronary sinus, and the IVC emptying into the RA. And in terms of the RV itself, in this view, we can see the anterior wall and the inferior wall. We next move to the parasternal short axis view. So from the parasternal long axis view, we rotate the probe 90 degrees clockwise. And this is the parasternal short axis view at the base of the heart. And so what you can see labelled here on the left of the screen is the tricuspid valve with the anterior and septal leaflets. And that flows into the RVOT and then the pulmonary valve on the right of screen. Right in the middle there is the aortic valve. Oops, we'll just go back. Right in the middle of the screen is the aortic valve. And here we're still in the parasternal short axis view, but we've angled the beam slightly inferiorly down towards the mitral valve level. And sometimes you can see the RV well here, but this is where it should be labelled, so it kind of wraps around the LV. And this view can help you form an impression about RV enlargement. And you can't always see the walls, but if you can, this is the ones that they are. So the inferior RV wall, the lateral RV wall, and the anterior RV wall. It's important here to look at the septum as well and septal motion. The next view we use to image the RV is the apical 4-chamber view. And right in the middle there is the cardiac crew, which will help you orientate yourself. And you see the septal and anterior tricuspid valve leaflets. And these leaflets should always be located slightly more apically than the mitral valve leaflets. And that's another check to make sure that you're orientated correctly, and to stop you getting, to help you not get so confused if there's aberrant anatomy, for example. To really look at the RV, we need to focus on that part of the heart. So this is an RV focused view from the apical 4-chamber. And we obtain this view by angling the beam slightly medially towards the right shoulder. And the idea is that we bring the RV free wall into view so that we can interrogate that in more detail. So that's the lateral RV wall there, or RV free wall is often how you'll hear it referred to. So just a little bit more detail about that. So your classic apical 4-chamber view is the one at the bottom of the panel here, where the LV apex is right at the top of the window, and the LV sits reasonably vertically within your window. But to really interrogate the RV and the RV free wall or lateral wall, we need to, as I said, angle the beam medially towards the right shoulder. And this is the recommended view for most of the measurements that we'll talk about in subsequent presentations. So the RV focused apical 4-chamber view is right in the middle there. So that's what we're aiming for. Sometimes you can't get it, but that's what you're aiming for. And then finally, we would move to the subcostal 4-chamber view, which is another view where we need to perform to assess the RV adequately. And this view is obtained inferior to the Ziffy sternum with the marker on the ultrasound probe at 3 o'clock. So this is a subcostal 4-chamber view, and you can get a subcostal 5-chamber view by just angling slightly superiorly. And what you see here is all of the chambers, so right atrium, right ventricle at the top there, left atrium and left ventricle separated by the interatrial septum and the interventricular septum respectively. And here you see the inferior RV wall and the anterior and septal tricuspid valve leaflets. And then the subcostal short axis view, so you rotate from the subcostal long axis, you'd rotate the ultrasound probe clockwise, so the marker is pointing upwards at 12 o'clock. And here at the top of the screen you can see the liver, just inferior to that is the RV, and then more inferior to that is the LV. And you can also have a subcostal short axis view at the base of the heart or the RVOT level. And right in the middle there is the aorta. You can see the tricuspid valve and the pulmonary valve, and the right atrium and the left atrium. Okay, so those are all of the images that you need to adequately assess the right ventricle. And now we're going to focus on chamber quantification. And the first way to do that is with visual estimation. And it's important here to do this in multiple views so that you can make as accurate assessment as possible of RV size. If you look at enough echoes, you'll get good at this. And, when you've seen enough, your visual estimation is actually reasonably accurate. And in ICU, it's usually the extremes that we're interested in. So, all the grey kind of moderate areas are not so helpful to us. But if someone has a significantly dilated RV, that is very important to us. And if you look at enough echoes, you'll be able to determine that, usually with visual estimation. Plus minus confirmation with other measurements. But anyway, so for visual estimation, you need to compare the relative size of the right ventricle to the left ventricle. And you may see reports that the RV is dilated despite it measuring within the normal range. And that's usually on the basis that the RV appears slightly larger than the left ventricle. A normal sized RV is less than 2/3 of the size of the LV. Mild dilatation would be when the RV is greater than 2/3 of the LV. Moderate dilatation is when the RV is the same size as the LV and they share the apex. And severe dilatation is when the RV is larger than the LV. Sorry about that typo there, and it forms the apex. So you can see here that the RV, I think, is probably about the same size as the LV, and potentially is moderate dilatation, but it is hard to see off just one view. So this is an example where the RV, I think, is bigger than the LV, or at least the same size, and they're at least sharing an apex there. So that RV dilatation is at least moderate, probably severe. And likewise here, I think, it is a little bit difficult to appreciate the RV free wall, but I think that RV is bigger than the LV and is forming the apex, so that would be severe dilatation. You can use linear measurements to determine RV size. Quantitation in this way or in any way does reduce interreader variability compared with visual assessment only. But 2D measurements are difficult because of the complex geometry of the RV and lack of specific anatomic landmarks. If you are going to do this, it's best in the RV focused 4-chamber, RV focused apical 4-chamber, because that's where the RV is focused, as it says in the name. Accuracy of the measurements can be limited when the RV free wall is not well defined, which unfortunately happens reasonably often. Because of its dimensions, so because it's so enlarged or because of where it's sitting, for example, behind the sternum. You need to measure when the RV is at its biggest, which is at end diastole, so it's important to have the ECG connected so you can get the timing right. The first measurement is labelled RVD1 on the left picture there, and this is the RV basal dimension. And normal is less than 42 millimeters. RVD2 is the mid-cavity linear dimension, and that's measured in the middle 1/3 of the RV, approximately halfway between the basal diameter and the apex about at the level of the papillary muscle. And you can see that might be hard to work out. And a normal mid-cavity linear dimension is less than 35 millimeters. You can also measure longitudinally from base to apex, so from the apex of the RV to the tricuspid valve annulus, and less than 86 millimeters would be normal. The advantages of this measurement are it's reasonably easy if your images are satisfactory. It's pretty simple, and there's lots of published data about normal values. However, the size may be underestimated due to the complex and crescent shape of the RV. And the dimensions are dependent on probe rotation and different views. So if you do it if you measure in just a normal apical 4 chamber as opposed to an RV focused 4 chamber, and that's demonstrated kind of here. So depending on how you cut through the RV, the linear dimensions of the RV can be significantly different. So when you're doing it, make sure that you document and note what view you're using when you make your measurements, so that the next person that comes along to do it can kind of try and do it the same to make them comparable. The American Society of Echo recommends that patients with evidence of right-sided heart disease or pulmonary hypertension should have these measurements taken, ideally basal and mid. In practice, you see a lot of people get basal measurements, and if they're normal, then they don't get a mid measurement. And that's kind of my practice. So the minimum would be the basal measurement, and then if you're worried about right-sided heart disease, add in a mid-cavity measurement as well. So this is an example of a RV basal measurement, which is enlarged. And another example of an enlarged RV with a large basal measurement. And you can see the kind of difficulty in where to measure it. It's hard to compare between scans. Again, visually that looks like a big RV, but that's confirmed with the large basal and mid measurements. You can also do linear measurements in the RV outflow region. So you can measure the RVOT proximal in the parasternal long axis, which is measured from the anterior RV wall to the interventricular septal aortic junction. Or you can measure the RVOT proximal also in the parasternal short axis view from the anterior RV wall to the aortic valve, and both of those measurements would be performed in end diastole or at end diastole. And then the RVOT distal measurement is the linear transverse dimension measured just proximal to the pulmonary valve at end diastole. And the normal values are listed there. It's documented as being an easy, kind of simple, fast measurement to do. I think it depends on the 2D images that you get. And personally, I think it's probably a bit more difficult. And it's not part of my normal practice when I'm doing an echo. It's also a regional measure. There's less data about normal values for these measurements. And as I said, getting a good enough image can be harder here. So the anterior wall is often poorly defined. And again, probe location and orientation can have a significant impact on the linear measurements here. So this isn't recommended as part of a normal kind of straightforward echo, but in selected patients with congenital heart disease or something like arrhythmogenic RV cardiomyopathy, this measurement would be performed. So another way to quantify the RV size is to measure RV end diastolic area. And this requires manual tracing of the RV endocardial border from the tricuspid annulus along the free wall all the way around through around the apex and back to the medial tricuspid, medial part of the tricuspid annulus. And you would measure that if you wanted to measure area at end diastole. You need to include trabeculations, the papillary muscles, and the moderator band within the cavity area. If you have decent images, this is relatively easy to measure in a sense. However, tracing the right area can be quite difficult. You'll find sometimes when you freeze images, which is what you'd need to do here, the definition isn't as good and it can be hard to work out where the endocardial border is. If your 2D image is foreshortened at all, you'll underestimate the size of the cavity. And because of the complex kind of crescent shape, it is easy to make errors here. So this isn't the best way to assess RV volume. It's got too many limitations and assumptions, unfortunately. And it's not recommended as a way to assess RV size. This technique of tracing the endocardial border at end diastole is part of fractional area change when you're looking at RV systolic function. So we will discuss it more. So you can definitely practice it and use it later on, but it's not recommended as a measure of RV size. Another component of RV size and I guess anatomy is RV wall thickness. So this can be measured by M mode or 2D and preferably in the subcostal view because in that view the beam is perpendicular to the free wall. You measure it at end diastole just below the tricuspid annulus at a distance approximating the length of the tricuspid valve leaflet when it's fully open. And trabeculae, pap muscles, and epicardial fat should be excluded. The normal value or an abnormal value is greater than 5 millimeters, so it would be abnormally thick. There's no criteria for defining an abnormally thin RV wall. I guess the issues are that it's a single site measurement. It can be difficult to identify the actual RV wall as opposed to thickening of the visceral pericardium, for example. It is recommended as part of a comprehensive echo, so if it's abnormal, it should be reported, and especially in patients with RV or LV dysfunction. Okay, let's look at some examples. So this is a parasternal long axis view with the RV at the top of the screen there. And what we can kind of say specifically about the RV in this view is that it doesn't look grossly enlarged. We've moved to the parasternal short axis view. This is at the mitral valve level. You can get the impression of some kind of septal flattening here and perhaps some RV dilatation, but if we move on, that actually looks quite normal and the RV doesn't look grossly enlarged in this view. So again, it's important to have multiple views to add to your assessment and try and not make a call based off a single image if you can avoid it. So we've moved to the apical 4-chamber view here. And my impression of this is that the RV is smaller than the LV, which is what we'd like to see. And same again, just to demonstrate that a little bit more clearly. Moving to the RV focused view. And again, that RV doesn't look particularly enlarged. It looks normal. Zoomed in a little bit more to demonstrate that more clearly. and a linear measurement that's consistent with normal RV size. Subcostal view, again, RV looks smaller than the LV, so normal. So all of those images demonstrate a normal sized RV. Next example, images aren't quite as clear. But you do get the impression in this view that the RV certainly looks bigger compared to the LV than in the example we saw before. And this is the apical 4-chamber view. And here you can see a grossly dilated RV, which is bigger than the LV. And my impression is that it's forming the apex. So that would be consistent with severe RV dilatation. And have zoomed in on the RV in the apical 4-chamber view to demonstrate the same findings. So yes, I think the RV is bigger than the LV and is the apex forming chamber, which is consistent with severe RV dilatation. And then just trying to focus on the RV with a modified view, trying to bring that RV free wall into view a bit more clearly. It's a bit hard to comment. I mean, we know what we've seen before, but given that the LV has been excluded, it's hard to comment on size here. So sorry, before we move on, all of those images are consistent with severe RV dilatation. All right, next example. Again, this is the parasternal long axis view, which might be a bit difficult to decipher. And again, within the limits of a single frame or a single image, the RV does look enlarged compared to the LV there. And here we can see the parasternal short axis view. And the RV looks grossly enlarged compared to the small LV there. And the colour doesn't add much here, so don't focus on that. But again, this is demonstrating a very enlarged RV compared to the LV. You can see the moderator band there in the middle of the RV. And now we've moved to the apical 4-chamber view, which shows a couple of things. Firstly, I guess the thing that predominates and almost takes over the whole image is the size of the right atrium. So that's grossly enlarged. And what else is reasonably clear, I think, within the limitations of the image, is that the RV looks much bigger than the LV. And from what I can see here, they're at least sharing the apex. So that would indicate to me at least moderate, but probably severe RV dilatation. And zoomed in further, again, the RV I think is bigger than the LV and is forming the apex, consistent with severe dilatation. All right, next one. So again, we always start with the parasternal long axis view. Not completely obvious what's going on here, but you do get the impression that the RV is perhaps slightly bigger compared to the LV. And just an example of the parasternal short axis view at the base of the heart. They won't add much at this stage. And here we're in parasternal short axis at the level of the mitral valve, and you can see that the right ventricle is much bigger compared to the left ventricle. And we've moved to the apical 4-chamber here. This is more an RV modified view in the apical 4-chamber window. And you can see that the RV is much bigger than the LV, consistent with severe RV dilatation. It's hard to see the apex there, but certainly on size, it looks severely dilated. And that's a very similar image demonstrating the same. And again, you can see that the RV is much bigger than the LV, indicating severe dilatation. I think they're really trying to image the apex there for us, which is proving difficult. But again, all of the images from this patient are also consistent with severe RV dilatation. So this image isn't amazing, obviously, but sometimes this is all you get, and this is where you start. To be very honest, there's little that we can say about this image. And with a bit of trial and error, I presume, the sonographer or the person doing the echo has managed to obtain this image. And you can see here in this kind of, it's a slightly different parasternal long in terms of angulation, but the RV looks really big compared to the LV. And again, and this is a parasternal short axis view at the level of the aortic valve. So the aortic valve's in the middle, right in the middle of the screen there. This looks a little bit different because this patient's had a tricuspid valve replacement. So the kind of loose, stringy appearance right on the top left of the screen is the prosthetic valve. And then when you put colour through it, that's what it looks like. These are just interesting pictures. Same patient, moved to the parasternal short axis. This is kind of at the mitral valve level. And you can see here that the RV looks really, really large compared to the LV. And that's consistent with the appearances in the apical 4-chamber view as well. So here the RV looks bigger than the LV, and you can't say for sure because it's not imaged particularly well, but you get the impression that the RV is the apex forming chamber, which is consistent with severe RV dilatation. Here are the major references for this talk. They're long documents, but they're excellent. If you're interested, have a read. Thank you. I'll see you next time.